stage 4 cancer patients should not be denied access. Their care should not be delayed because they have to go through a failed treatment regimen first.
This is the James Cancer-Free World podcast. I'm Steve Wartenberg, and my guest today is Jennifer Carlson, the James Associate Vice President for External Relations and Advocacy in the Office of Health Sciences. I usually talk to James scientists and physicians about the latest and best cancer research and life-saving treatments, so today will be a little bit different. Jennifer's job is to help all these great James researchers and physicians push the needle forward, and also to make cancer treatment more accessible to everyone, especially underserved populations that struggle to get access to good health care and screenings. And we'll also talk a little bit about the added challenges of the COVID-19 pandemic. Welcome, Jennifer.
Thank you. Thank you for having me today.
It's great to hear. It's great that you're here and to learn about something a little bit different than we usually talk about. So your title, Vice President for External Relations and Advocacy, what does that mean? Sort of explain your role here at the James and the Comprehensive Cancer Center.
I advise and work with our senior leaders on all matters regarding health policy and strategically positioning us in the enterprise in the external environment. And so my office gathers and disseminates information on federal, state, and local laws and regulatory matters. And we educate our opinion leaders on priorities that align with our strategic plan. And we advance strategies to promote priorities for OSU within all levels of state, federal, and local government. And so it's an exciting position, and I'm really pleased to be working at Ohio State.
So you mentioned that one of your goals is to establish priorities. So what are a couple of those for the James? I've been hearing a lot lately about your expanded cancer drug take-back program.
And so over the past few years, we've worked with the State Board of Pharmacy on new rules governing the operation of these drug repository programs. And that allowed for, at the time, a narrow collection of unused medications. And those medications were placed at pharmacies, hospitals, nonprofit clinics, and then they could be redispensed to patients who couldn't afford the cost of medications. And so earlier this year, the state of Ohio stood with us, the leaders of the James Cancer Hospital and Soloff Research Institute, to announce the modifications of that particular regulation. And so what we wanted to get at more specifically was the donation of orally administered cancer medications and other drugs used to treat side effects of cancer care. And what we specifically wanted to get at were the drugs that were previously opened and in the physical possession of an intended patient, because that was not allowed under the regulation. You can only imagine, the monthly costs of medications. It can be in the thousands of dollars for patients. And that's why financial assistance in the new medication program is so important. It's quite common for patients to switch to a new medication or change doses, and that results in wasted medication that currently must be disposed.
That means thrown out.
Yeah, right. And
Okay.
and that could be complicated too, especially when you're dealing with, for example, chemotherapy agents. But this new program, patients with these unneeded medications now can donate them for redispensing to patients who can't afford them, can't afford the cost. And so these donated medications, we closely inspect them. It has to be within the expiration dates. It has to be stored according to how they're being prescribed and otherwise untampered with. And so the drugs undergo a very rigorous specific inspection process by one of our pharmacists. And then they're stored in a separate inventory for when a patient is deemed financially eligible and approved to have these donated drugs dispensed. And so we have a team of fantastic pharmacists individuals reaching out to our patients to say, "Hey, we've got this bolus of product here that we know you're a perfect fit, and we want to be able to help you in this time of need." So we've started this program. We have at least 2 oral therapies right now that we've used in a variety of oncology disease states. And so we're establishing best practices, and we're intending to take out and expand the repository in the near future to serve all patients across the spectrum and that may have a financial need. And so really appreciated the strong partnership and collaboration we've had with the State Board of Pharmacy and the State of Ohio and Department of Health in making this an innovative patient care model possible. And now we're also pushing the word out and helping to educate other providers across the state, across the nation, and saying that this repository program to assist patients is well intended and is something that should be implemented across the nation. So we're pleased.
Now, are you one of the first or even the first to do this in Ohio?
We are. That's one of our points of pride. We are one of the first. We are the first in the state of Ohio to do this. We felt that this was an important thing to do for the community, for our cancer patients. And so we take pride in what we've been able to accomplish and provide to our patients.
It's interesting because over the past couple of years in talking to people, the James has been the first in the state and even the nation to do a lot of things like the Lynch screening program across the whole state. And now the first to do this pill exchange program. And these can serve as, I'm guessing that you hope, as national models that other states are going to do as well.
That's true. I mean, we've had this wonderful history of being first in class and advocating and promoting strategies that help our cancer patient. We can point to several different initiatives, access to cancer clinical trials. When I first got to Ohio State, there were broad insurance exclusionary provisions that prohibited patients, even though they were eligible, screened. We knew that standard of care wasn't working for them, wanted to put them onto a clinical trial, yet there were barriers to access. And we were able to break down those barriers through state and federal legislation that's just one more points of pride that we use. We've been able to disseminate and push out into the communities this best practice where you have to make sure that insurers understand that clinical trials, the only way you're going to be able to change standard of care is to advance clinical trials. And that insurance companies, when we put our patients onto trial, we're not asking you to pay for anything more than what you normally would pay for. And that would be the routine costs of the doctor visits, the blood tests, and all the clinical trial testing, which could be a pill a day. That's what would be charged off to the university or the sponsor of the trial. So that again is just a point to how we look for ways to further advance policies that help our patients, and we look for ways that we can amplify our successes and how we've been trailblazers at Ohio State University.
Yeah, and just talking to you, I don't think I realized the extent of the different groups you need to talk to. Insurance companies, state and federal regulators, the FDA, all these people are involved in creating the policies that impact anyone who's diagnosed with cancer.
That's right. And most people don't understand that until they're in the middle of a crisis and their family members or themselves are hitting the James, and they don't understand the nuances and the complexities of their insurance, and this is where we take a broad brush look at all policies, and in my position, I have the ability to work hand in glove with our elected officials, with our regulators, and we try to have those conversations early on so that they understand the nuances and the benefits of what we're trying to promote.
I feel like because the James is so well known throughout the state and the state regulators are here in Columbus, that I think and hope they understand the importance of pushing the needle forward.
They do. We spend a lot of time having personal conversations with our elected officials. I even point to, during this trying time during COVID-19, when most individuals are having Zoom conversations like we are today, we for the past several months, we've been having informational briefings just to keep our elected officials up to date on what's going on. And in fact, I do have staff going down to the State House this week to talk about a really important piece of legislation that we're advancing on the House side, which is the Stage 4 bill. And I'd like to talk to you a little bit about that as well.
Well, great. That's on our list, and I've heard about this, and it's an example of how the James is a state and national leader and a new thing that's going to help people. But first, we're going to take a quick break, and then we'll be right back with Jennifer to learn more about the Stage 4 cancer bill that is, I think she's going to tell us how it's going to save some lives.
A revolution in lung cancer treatment is happening at the James. We're proving lung cancer isn't solely defined by location and stage, but rather the individual molecules and genes that drive it. Simply put, there is no routine lung cancer. That's why our world-renowned specialists put their expertise towards treating one particular lung cancer, yours. At the James, we go beyond the routine to prevent, detect, treat, and cure your lung cancer. To learn more, call 1-800-293-5066.
We're back with Jennifer Carlson, the James Associate Vice President for External Relations and Advocacy in the Office of Health Sciences. And Jennifer, you were about to tell us about this Stage 4 cancer bill and fill us in on where it's at in the state legislature and what it's going to do to help people.
Sure. Thank you. You might find it surprising to know that insurers can deny care even though a physician knows the drug mandated by the insurer will be ineffective based on the specific patient or the known side effects of the drug regimen. When we learned about these challenges that were popping up from an insurance perspective, we started to have conversations with our government agencies, Department of Health, Department of Insurance, Department of Medicaid, various cancer-centric organizations, clinical associations, and what ultimately led into the development and the introduction of the Stage 4 cancer bill, which was announced at the James earlier this year, along with Senators Bob Hackett and Senator Herschel Craig. And that bill is Senate Bill 252. And so what it would do is it would prohibit the use of fail-first requirements or step therapy.
Fail first meaning this is the way it's been done in the past. You got to use this drug, even though the James doctor, who's an expert and knows this patient and what they need, says, no, we don't want to use drug A. We want to use drug B. We think it'll be better.
Precisely. And so at the James, I think it's really important to note that approximately 20% of our patients are diagnosed with Stage 4 disease. And what that means is their cancers has spread from the original site of the cancer to other parts of the body. So it's a little bit, it's more complex. So there's an exciting time in cancer treatment because there's new targeted therapies, and in some cases, making metastatic disease a chronic disease. However, the opportunities to achieve that state requires patients receive the right to treatment at the right time. So Senate Bill 252 would ensure the coverage of a drug to treat metastatic cancer or its associated conditions or side effects is not dependent upon failure to successfully respond to a different, and in some cases, less expensive drugs. So it would allow for a drug that's approved by the FDA for treatment of the type of cancer the patient has, or a drug that's included in the National Comprehensive Cancer Center Network Drugs and Biologic Compendium. So essentially, the bill permits chemotherapy use that's consistent with best practices for the treatment of cancer as supported by peer-reviewed medical literature without delaying a patient's care to require them to fail a prior chemotherapy medicine. But typically, there's a reason why the physician chooses one treatment over another, and it's based on the patient's unique cancer or the unique side effect of the treatment. As long as that is consistent with the FDA guidelines, as we talked about, or national guidelines like the NCCN best practices, and insurers should not be able to override the physician's selection of the drug regimen. So this bill would make it very clear that if it's offered within the insurance coverage, that stage 4 cancer patients should not be denied access. The care should not be delayed because they have to go through a failed first treatment regimen first. And so the bill is pending right now in the Ohio House, and we look forward to its passage before the end of the legislative session this year. And we're pleased to be working on, yet again, another trailblazer legislative initiative.
So another thing, since we first scheduled this a couple months ago, there's been quite a few changes in the world through COVID-19. We're doing this remotely. I'm sure you're doing a lot of your work remotely. How has COVID-19 sort of changed what you do? And also, how are you using it, or not using it, but what are you doing to sort of make things easier in this difficult times to interact with and help patients?
A good example is when we knew we had to roll back on optional surgical procedures, but knowing that there were some procedures that we continued to need to do within the James, but we also needed to be able to have those really important follow-up clinical discussions that our physicians needed to have with their patients. And so we quickly mobilized. We had conversations with the administration, both on the national and state level, to say telehealth services is critically important, yet we need those flexibilities. We need the flexibility to be able to have conversations like you and I are having today, face-to-face interactions with our patients, to do it at a broader scale. So back in February, just to give you some perspective, monthly we were having about 50 telehealth encounters, and those were telehealth consults that our providers were having with our physicians. Now we're having over 2,300 per month. And so that gives you a sense and the magnitude of how we've been able to change care and allow for that critically important dialogue between our providers and our patients. And it's also a safe way to provide care, because we want to make sure that only those individuals that have to come into our hospitals or our ambulatory care centers are coming in. And if you don't need to come in at this point in time, we want to continue to be able to provide services through telehealth. So it's been interesting. We have daily leadership calls talking about the care that's needed, the testing, the modeling, the forecasting, not only as it relates to COVID, but how can we take to scale and make sure that the other resources that might have been potentially put on pause gets brought up in a quick fashion, because we need to make sure that those services are out there and open to our patients during this time.
Dave Cohn was just on the podcast a couple of episodes ago to talk about how it's time to get back, for people to get back on their track for screenings, how vital that is. So I think that's an example of what you were just talking about.
Absolutely. We want to make sure that nothing pops out on the other end. When you think about instilling consumer confidence, and so we've spent a lot of time working on messaging, outreach to our patients, but outreach also to the administration and our elected officials so that they understand. We're open. We're prepared. We have the right screening mechanisms in place to protect our faculty, our staff, our patients, and so that's really important. But to your point that David likely has mentioned, screenings are down. We are trying to amplify that. We have safe facilities. We want our patients to come in to make sure that they're getting their, breast cancer screenings, their colonoscopies, all those important frontline of defenses before things could go turn in a different way for our patients. It's really important. Right. We know that children's inoculations, for example, are down about 60%. Mm-hmm. And so it's really important that government providers all work together to make sure that our patients are coming back for these important screenings.
I like to ask this question to doctors who deal directly with patients. And while you deal indirectly with patients, I think I'm going to ask you the same question. What drives you, motivates you, has committed you to dedicating your career to do this?
Well, first of all, I'm a public policy junkie, and so that drives me to really be interested in all kinds of issues pending in front of Congress and the General Assembly, and also developing public policy. But I think more importantly, it's the James is an amazing place, and we have so much to offer our cancer patients, and I'm driven by the progress that we make and the incredible individuals that I work with, and the hard work that is done within the community. And it really goes back to the patients. Patients really motivate me, and I know that we can do more to help them, and especially our most vulnerable patients. And that's why I love doing my job.
Well, thanks for sharing that. And I think, to me at least, the thing that came through pretty clear is that the two words you just mentioned, public policy, are just more important than people realize in getting all this amazing research that's being done at the James and elsewhere around the world to patients. You need great public policy, and you need people like you pushing it forward. So thanks for doing that.
Thank you. Yes, I'd love to do whatever I can to make sure that we spread the word and grow more informed advocates out there.
Okay. This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard J. Solove Research Institute. For more information, check out our website, cancer.osu.edu.